So there are a couple of ways that people get diagnosed with colon cancer. You can do it on a screening where basically you're getting your colonoscopies and you're checking to see if you have colon cancer or sometimes what we call precancer. And then there's a situation where you actually get admitted to a hospital because your blood is really low, you're very iron deficient, and then it's during that admission you kind of discover a new diagnosis. So in the screening setting, you get your colonoscopy and they do what's called a biopsy, right, Dr. Doherty?
Yes.
And when that biopsy shows cancer, that GI doctor or the gastroenterologist will then usually refer you to a colorectal surgeon. What do you do after you're referred with somebody with a new cancer? What's kind of the way you go about what needs to be done?
Well, first we set them up, obviously, and they come into our office for an appointment. And then we see them. We do, a quick history and physical, which is an overview of their health and previous surgeries, previous medical histories. We'll talk about family history of, certain sorts of cancers like colon cancers or other cancers. And then we'll review pathology at that point. We'll try to get the specimen results from the gastroenterologists and then discuss next steps, which is usually staging. And at that point, staging will involve things like CT scans of the chest, abdomen, and pelvis. And then for rectal cancer, is an MRI or an endoscopic ultrasound, as well as some lab work.
So that's an important thing. When you get diagnosed with cancer, a lot of times the first question somebody asks is, well, what stage am I in? Is this curable? But that's not something that you can really, ascertain or figure out until you see a colorectal surgeon and really look at the pathology or anatomy during the surgery. When you're asking those questions about, say, past medical history and everyday health, what's the reason you're asking those questions?
Some of that is to really ascertain, family history, because is this a genetic sort of cancer? Also, are they a great operative candidate, or is it something we may need to treat more of a medical basis if they may not tolerate a surgery? And then other things are they on blood thinners and things like that, which will affect the surgery, and things we need to plan ahead, like do they need to see their cardiologist ahead of time for clearance and things like that.
So that's an important point. The physical health of a patient really kind of dictates, even in a curative setting, if you're able to be cured with the surgery or not. And that stage that you figure out is also not just necessarily on the imaging that you may order after you see them or when you do those extra kind of visualizations with the camera. Really, ultimately, the stage of the colon cancer and whether it's curative, and if it is, how high risk is it for it to come back only after the cancer is out, correct?
Right. We can usually tell if someone is a stage 4 on the imaging because we would see possible metastatic disease in other organs. But with regards to stage 1, 2, and 3, we really can't determine that until after surgery.
And that's important because that staging is really what determines if after the fact you may benefit from chemotherapy. So we look at a lot of studies to see, does stage 1 really need chemo to decrease the chance of recurrence? And it looks like no. If you're a stage 1, there isn't evidence that says doing all of that chemotherapy really changed your survival because it's pretty good. And then with stage 2, there's a couple of factors you could consider high risk. And then stage 3, we call it stage 3 because it's something that has a high risk of coming back. And that's when you will see the medical oncologist to then talk about those risks, the benefits of the therapy, and kind of what's involved. So if it is curative, and there are times when sometimes you want to reduce the cancer size at first with chemotherapy, which is what we call neoadjuvant. And so Dr. Doherty will even text me and say, hey, I think this guy will be, benefit from getting chemo to shrink it first, and then I'm going to take it out. But whether you get the chemo first or you're doing it up front, what are you doing exactly? Are you taking out the whole colon, just the piece of cancer, and what's involved?
Right. So it really depends. Very rarely do we take out a whole colon just for a single cancer. It would really need to be a genetic issue or synchronous lesions or things like that. Generally, we're taking out just a portion of the colon with the lymph nodes associated. So say it's a right-sided colon, then we will perform a right colectomy and take the associated lymph nodes. We can also do a left colectomy, a sigmoid colectomy. And then when you get down to the rectum, we're talking about things which are called anterior resections, which is a rectal resection.
Gotcha. And so most people that get a curative, so when we say hemi, you mean half of the colon, most people just require that. Where does it come into play with the whole bag concept? Is that something you worry about in colon and rectal cancer, or?
With colon cancer, for the most part, Most patients won't need an ostomy. Very rarely do they need an ostomy with colon cancer. And even with rectal cancer, the majority of the time, we're talking about a temporary ostomy. There are cases with very low rectal cancers that we are unable to do a resection without taking what we call the sphincter complexes. And when that happens, we do have to discuss with the patient a permanent colostomy. But again, those are for very low rectal cancers or tumors.
And basically, a colostomy is where you're actually taking, so if it's a full pipe from the mouth all the way down to the anus that basically disposes of what you consumed, you're cutting it and you're just sticking it onto the wall of the body. And instead of the products coming out from the rear end, they come into the bag. One, what happens to the rest of the, intestine or pipe that's now not having things go through it? And how reversible are they? And are there usually complications, or for the most part, are you able to just glue it back together and have things functioning?
Yeah, normally, if we are doing a colostomy, it's what we call a loop colostomy, that we bring up basically with two ends, just temporarily. And that's to let the anastomosis that's further down heal. And then once we know that the patient doesn't need any further chemotherapy, or they're a couple months out from surgery, it is a smaller procedure to just bring up that loop and reconnect. Now, again, sometimes patients do get what we call end colostomy, and if that's the case, we have taken everything out beyond the colostomy, and that is a permanent situation. But usually it is a loop situation that's a little bit easier to reconnect.
Awesome. So it sounds like the timeline is basically you get a diagnosis of colon cancer, and during that colonoscopy, unless you're very lucky, sometimes they actually will cut out, a polyp and it shows a tiny piece of cancer and you're done. How do you know if you're done if you cut out a polyp and it did show cancer? How do you know if there's some more left, or what is the thinking with that?
It depends on the depth of the invasion. There are even some T1 cancers, especially in the rectum, that we can remove transanally or with a scope and then follow without any further treatment. So that's why we do really reinforce getting colonoscopies, because these cancers can be prevented, especially large polyps and early cancers can potentially be removed with the scope and without a surgery, and then just followed. Now, sometimes it is aggressive, a scope every 3 to 6 months for a while to ensure that there's no regrowth or any concern. But for the most part, some of these cancers can be treated endoscopically.
That is just such a novel concept, is if you get your screening and you see something that's high risk, that's what dictates if they say, somebody tells you need a repeat in a year or 3 years or 5 years. It's because we have an idea of what the tumor biology looks like to know if there's a higher chance of it coming and how soon. And if you can spare yourself, getting half of the colon out, or God forbid, if you, spread to a stage 4 setting, all with just getting a polyp removed and not even requiring a surgery, it's a pretty novel concept. And so that screening that we're talking about, because we've realized it can really spare you having those complications we mentioned, that's why just as of recently in 2021, it's May 2021 now, people that are 45 and older qualify automatically across the board to get a screening colonoscopy, because the risks of that colonoscopy are felt to be significantly lower than the potential of a cancer spreading and growing too big to where it has to be resected. So number one, getting those colonoscopies and screening can definitely either catch a cancer early or keep you from getting a cancer. If you have a cancer that can't be taken out on a colonoscopy, you're going to get a biopsy, and you're going to usually be sent to a surgical specialist, a colorectal surgeon, who's going to walk you through, get an assessment of your health, how you feel. Could this be genetic related? What studies do I need to do for genetics? And then if it looks like you're a good operative candidate, or meaning you're in good health to get your operation, you're going to get a full staging to get an idea of the extent of the disease. And I guess depending on what you see, that's where you're going to hear your options from a colorectal surgeon about how to proceed. And then based on that, pathology of what comes out, they will usually send you then to a medical oncologist who can tell you the staging and the percent chance of recurrence, and maybe what options are available that the data shows to decrease your risk of a recurrence. But it's very important to follow with your colorectal surgeon even after you've been cured or had your surgery, because they're the ones that know the guidelines and the follow-ups and the, the post-operative complications.